Her talk today is developing and scaling evidence-based interventions and partnerships for evolving community priorities. Dr. Kiene is a professor of global health in the division of Epi and Biostat and the director of building research initiatives advancing global health equity at San Diego State University School of Public Health. Dr. Kiene is also an honorary professor of Makerere, right? Makerere. Close.
That's okay.
University School of Public Health. And she's got an amazing record. She's got 4 R01s right now, which are still going and doing quite well, global. And so very pleased with that, doing some excellent work. And we're very thrilled to have her here today to talk with us. And I'm going to turn it over to you.
Okay, thanks so much. Well, I'm really excited to be with you all today. Thank you so much for sharing your lunch hour with me. Okay. So today I'm going to talk about a couple of studies, and I'm kind of bookending that with just a couple of things for us to ponder. And I am not titling this, I didn't give the titles of the studies, but more just some things that kind of will make us pause a little bit. So before we get started about the research, I've been thinking a lot lately kind of about the kind of mistrust of public health, and especially as kind of academics and as academic public health folks, kind of what should we be doing about that? And as I've been pondering that, I was thinking about, well, what does the public and public health mean? And so I looked up public in the dictionary. And public can mean, as a noun, the community. And I selected things I thought were important. As an adjective, it means available to everyone, which is probably something we think about the most when we think about public and public health. But it can also mean something that's generally known. So we'll think about these things kind of as we go through this work, and I'll come back to these kind of at the end. So to start off this first kind of work, I'd like you to think back to 2020, the beginning of 2020, which was when the COVID pandemic was beginning. And I'm asking you to think back because I know now that we can all go to the store and buy COVID tests, and it really seems super simple. I want you to think back what it was like before that time. So does everyone remember the lines to get tested for COVID? So this picture is actually from 2022. So that in 2022, at least in San Diego, there were still lines to get tested. And so in San Diego County, like in other parts of the country, minority communities were facing disproportionate burdens of COVID. So particularly, I'm going to just illustrate this among our Hispanic Latino community. So they make up 34% of the population, but yet we're experiencing 50 to 53% of COVID cases, hospitalizations, and deaths. Now, of course, there's a number of reasons we can use to explain this. And these reasons are also things that underlie barriers to testing. And that's something that when we started doing work around COVID, that we decided to focus on is around barriers in access to testing. So we formed a community coalition of CBOs and the County of San Diego Health and Human Services, which we became known as the COVID Care Team. And they came up with this name, Communities Fighting COVID, which became the umbrella name of all of our COVID research projects, which included COVID testing and vaccine projects, which I won't have time to talk about all of that today, but I'll just talk about a little bit of the work under this kind of umbrella term. So when we started doing work on COVID testing, guided by what the COVID Care Team was suggesting, we really thought that the model was really PCR testing at the time. everyone was doing PCR testing, but we felt that rapid testing was what was needed. And so why were we not doing rapid testing? And why were we not doing testing really in the community with rapid testing? And why not by community health workers? We knew from HIV testing, and particularly in some of my work before COVID, that community-based HIV testing increases reach, it increases access, it's sustainable, and it also identifies infections earlier. So we had an evidence base to work from. Granted, it's not COVID, but given the moment, it seemed appropriate that we could move forward with rapid COVID testing in the community by community health workers. However, we faced a lot of resistance around this. People were saying, well, you can't do that. And we kind of had to be very persistent. We also faced resistance around, well, we don't want to partner with you to locate testing, with our organization. Everyone was scared. We finally, after a lot of persistence, knocking on a lot of doors, we got a church to agree to co-locate testing at their church. And we also, with a lot of persistence, finally got the county to agree that we could do rapid testing in communities with community health workers. We were also fortunate to work with Quidel Corporation, who donated all the rapid tests that we used. So it was really the confluence of these partners at the beginning that made all of this happen. Over time, kind of what we did, where we were able to test, did evolve, but this is how it all started. So the first study was funded by the Rapid Acceleration of Diagnostics Underserved Populations Initiative, which, as I mentioned, was community-based rapid antigen testing. Then we started working with a school district, which then that led into what we call the Return to School study, which I'll talk about a bit. And then we eventually also worked with a project called Test to Treat, where we were incorporating Paxlovid treatment as well. So just a little snippet from kind of the impact of our community testing. Consistently over time, our positivity rates in our community testing sites were higher than the county testing sites. And this was especially during COVID surges. So we interpret this as that we were reaching the populations most affected by the COVID pandemic in our region, which were really the populations that we were trying to reach. So moving to our Communities Fighting COVID, Returning Our Kids Back to School Safely project. This was a study that we partnered with the Sweetwater Union High School District, and we were jointly awarded funding with them. And despite their name, it's a bit of a misnomer. They also have middle schools. So we actually worked in the middle schools of this district. So we were one of 16 sites nationwide that was part of this Return to School program from NIH. So when we were working with the school district, we started doing testing with them on site at their schools. And while they really liked that because kids could get tested regularly, they could be tested every week, they felt like it was a big logistical burden to have that in the schools, to be able to kind of support that. And we knew that at-home testing was going to start becoming available. And so we talked about, well, do we think that this is a model that could work? Could we start giving out at-home tests? But we didn't really know if we would get the same participation. Would kids keep testing every week if we're giving out at-home tests? So we didn't really have the evidence that at-home testing would be kind of equivalent to the on-site testing. So we did a non-inferiority trial to see would participation be the same if we were giving out at-home tests. And what we found was that at-home testing was not inferior to on-site testing, both for participation rate and adherence to weekly testing. And what I mean by participation rate is we're looking at over 22 weeks of our trial, looking at what percentage of each school was testing that week. And so over the trial, what percentage was testing. Then we're also looking at adherence to testing. So once someone started testing, did they continue testing every week? So it was at-home testing was not inferior on either of those metrics. So we had good evidence for that, but we also wanted to make sure, was at-home testing acceptable and appropriate compared to on-site testing? Now, I will say that we kind of expected these to be kind of equal, but to our surprise, actually at-home testing was perceived to be more appropriate and acceptable than on-site testing. So that was a bit surprising, but I suppose all in all, a good thing. So then with that evidence, we proceeded to scale up the at-home testing model, first to 9 of the 11 middle schools, and then with the start of the new school year to all 11 middle schools in the district. This was a school district that has a non-traditional calendar, so year-round calendar. So at the start of the new school year, we scaled up to all 11 schools. Then, kind of at the end of 2022, we started seeing reduced community transmission. And also kind of with that, the school district changed some of their mandates around testing. So previously, students had to test for certain activities, such as some sports and some after-school activities, and they kind of dropped those mandates. So it made sense to change from this weekly testing model to what we call the real world model of kind of test when you think you need to test. We provided some recommendations around that, which were, test before and after large gatherings, maybe family gatherings. Obviously, if you have symptoms or if you think you've been exposed. And then eventually, with kind of the ending of the study, we kind of phased out testing and kind of stopped providing guidance and let people test as they wished. So all told, we gave out almost 80,000 at-home tests. Just over 40,000 of those actually had results reported. And I'm happy to kind of explain my thoughts on that later, but it was a burden for people to report results, as you might imagine. We identified 787 COVID cases through this. We also did around 5,500 on-site tests, which were part of the trial. Interestingly, during the full-scale implementation, which was during the 2022-2023 school year, we saw that schools that had lower participation rates in testing had more student absences due to COVID than schools that had higher participation in the testing program. So for example, in a school with around 850 students, so this is just projecting because schools had different sizes. With 850 students, they would have around 1,400 student days missed versus high participation, around 660 student days missed. So then when we were working on our community dissemination efforts and thinking about preparing our infographics, our videos, which is a big part of this project, we were really thinking about, well, what do community members want to know about what we did in this study? They don't necessarily care about what the results of the non-inferiority trial was. What's important to them? So we kind of reflected on findings of a multitude of data we collected, which included some qualitative data early on, parent survey throughout. And something that kept kind of coming up was that parents kind of were reporting that the program made them feel safer sending their kids to school. And to us, that seemed like kind of an important thing that came out of this that community members would want to know. And it also kind of coincided with the overall goal of this NIH initiative, which was, the safe return of kids to school. And for me, this was a really important kind of lesson as a researcher in terms of thinking of what is it that is important to community members and trying to figure that out, and also working with the school district to try to identify that, because oftentimes we struggle to translate our kind of nerdy research findings into things that people find interesting. Okay, so switching gears, so kind of the next kind of story, I'll call the usefulness of a good theory. So switching gears to Uganda and the HIV and hazardous alcohol use, and specifically in Ugandan fishing communities. So in fishing communities, HIV prevalence can be as high as 30 to 40%. And Uganda also has very high per capita alcohol consumption. It's 3 times the Africa region average and over twice the global average. And fishing communities also have very kind of unique physical and social environmental determinants of both HIV and hazardous alcohol use. So how this line of research really started was I'd been working in Uganda for a number of years, and this was a while back. I've been working there for a number of years, and CBO contacted me and said, "Well, we got your name from someone, and we are located near the fishing villages, and we want to do some work around HIV prevention and alcohol use because we recognize it's a problem in these communities. And we'd really like to do this popular opinion leader intervention." And I said, okay, well, let's talk. Let's see what, might make sense to do. And this was back a while ago. And so we talked, and I said, well, and they wanted to apply for a grant for this. So we talked, and I said, well, the bad part is that the popular opinion leader model outside of the US, there was just a big study that showed that model didn't work outside of the US. So I said, I don't know that we should go with the popular opinion leader model, especially if we want to get funding. So we decided we would kind of start from scratch, especially because there wasn't really evidence for effective alcohol interventions in Eastern and Southern Africa. And the citations I have there are actually more recent than this work, and that's some work by our team. So we felt like we didn't really have anything we were ready to implement. So we kind of put a pause on that and went back to the drawing board. So what we really learned in kind of our formative work that we ended up doing was that what we call cash in the pocket was really a key driver of alcohol use and HIV risk. People get paid in cash when they work, oftentimes on a daily basis. And this was something that would then kind of lead to going to the bar to drink or paying for sex. And there was little other kind of leisure activities or little else to do. So it was kind of described also as like an enemy in the pocket. And then also described that, well, before they came to the fishing community, they didn't do these things. So the quote, which is the title of this slide, as "Such behaviors are not in my home village, I got them here," suggesting that they're learned things once someone arrives, and it's really the environment that's producing these behaviors. Men also had ideas for solutions of, well, how do we solve these challenges? They felt that they needed accessible ways to be able to save money. And one way they proposed was using mobile money, which is like a mobile banking that's on your with your phone provider. So not quite like mobile banking as we might think of it, but more through your cellular provider. And so kind of using that, we tried to think of, well, what theories can we kind of match to their ideas? to really have some theoretical perspective on why both kind of how we understand that this is unfolding and also why such an intervention might work. So I came across behavioral economics really in the context of substance use and thinking about kind of reward in the environmental context. So I think most people, when they hear behavioral economics and public health, they think of nudges. That's not what we're talking about here. We're talking about more in the substance use realm, where there's a few different principles that we think about. So the first is delayed reward discounting, or sometimes we just shorten that to delay discounting. And I think many people are familiar with this concept. So this is really the preference for immediate, smaller rewards over larger rewards in the future. And then, but the delaying the time to reward actually tends to decrease the devaluation. Now, it was thought that this was kind of a fixed thing, that you couldn't really change this. But more recent work has really shown that you can change this through intervention. The second principle is around alcohol demand, or the reward value of alcohol. So this is really like the amount of effort or output, including money, that someone is willing to expend in order to drink. So to what lengths will they go to in order to drink? How much will they spend in order to drink? And then kind of countering those two are alternative reinforcers that are available in the environment. Are there accessible alcohol-free activities that are enjoyable to someone? Are there hobbies they can engage in? Is there entertainment? Are there family and friends they can spend time with? Personal enrichment. And those can serve to kind of counterbalance these other two factors. So then, applying these behavioral economic principles with substance use, the Kisaboka intervention was born, and Kisaboka means it is possible. So applying delayed reward discounting, we work towards developing delayed rewards through financial goal setting and developing discrepancy between current behavior and future goals. Then for the reward value of alcohol, this is where addressing the cash in the pocket part comes in. So the idea for this was setting up mobile money for work pay. So getting paid via mobile money instead of cash to help kind of reduce that easy expenditure of cash on alcohol. There's also other literature that shows that having kind of money less accessible through these kind of soft commitment mechanisms, such as like mobile money, can reduce unnecessary spending as well. So there was other literature supporting this. And then in alternative reinforcers, we kind of operationalize this as things like soccer, TV, Ludo, which is a board game, and also starting up new small businesses. So these were the behavioral economic components of the Kisaboka intervention. So ultimately, this intervention kind of embodied community-generated solutions to challenges that they identified. And so we went through what you might imagine was a fairly long phase of intervention development, and then did a pilot RCT to really inform modifications in preparation for a larger hybrid trial, which is where we're at now. So in our pilot of Kisaboka, we worked in Wakiso district, which is the district that's highlighted in orange. This map is great in that it allows you to highlight districts, but it doesn't show the water body. So this is on Lake Victoria, which is a large lake in East Africa. And we recruited from both island and mainland sites, HIV clinics, sorry. And so this was with men who were living with HIV and reported hazardous alcohol use, and also kind of were struggling with antiretroviral adherence. They worked in the fishing industry and also needed to have a mobile phone. And I will note that our study was taking place kind of during some COVID lockdowns, and you'll see kind of why that's important in a minute. So we did find some promising efficacy for the intervention reducing very hazardous alcohol use, both for a self-reported alcohol use measure, which is the audit C, and for a biomarker of alcohol use, which is PET. So in both cases, for the intervention, we saw decreases between baseline and follow-up. For the self-reported, we saw slight decreases, but for the biomarker, actually increases in the comparison arm, which was a screening and referral arm. We also saw some promising efficacy for our HIV-related outcomes, which were self-reported adherence and HIV viral load. For adherence, you see that Kisa-Boca was protective against decreases in adherence that we saw in the comparison arm. This is kind of where the potential COVID effects come in, because of lockdowns, people may have had difficulty accessing clinics, picking up their refills. Obviously, we don't know that for sure, but that's kind of what may have happened. For the HIV viral load outcome, we did use just routine clinic data, so there's a lot of missing data here. This was kind of a secondary outcome due to limitations of the pilot, but it did show some kind of promising signal here of increasing over time in the Kisa-Boca arm. Then our exit interview data provided some interesting support for the behavioral economic theoretical mechanisms of change. So in terms of support for decreasing alcohol demand, so this man said, when money is on the phone, it's not easily spent like how it would have been if you had it as cash in your pocket. Then I'll just skip some of that. You decide that you will not withdraw your 10,000 shillings from the phone and as such forego taking alcohol. We also found support for developing discrepancy through and making that develop delayed rewards. When she calculated for us our alcohol expenditure log, whereby we would sometimes spend 500 or 50,000 shillings a week on drinking, or even 100,000 in one day. But if you save this money, you can even buy a goat in 1 week. And then lastly, by finding alternative reinforcement, this tempered environmental determinant. So this man kind of describes that he changed kind of the people he was hanging out with, and he would use the money that he would have otherwise spent to invest in buying a goat or a pig. And he comments that because after the counseling, I changed everything that I did. So we also felt that it was important to really document modifications that we made that were informed by what we learned during the pilot. So we used the framework for reporting adaptations and modifications, so we could keep track of modifications we were making as we were going to be scaling up for the larger trial. And I'll just share a couple of examples of modifications that we made based upon our data. So we found some challenges with feasibility of the mobile money to receive work payments, and this is something that happened during the trial, that a lot of men changed employers frequently. They may have had multiple employers, they may have been self-employed. So kind of this universal implementation of using mobile money for work pay was not feasible. However, they actually came up with their own solution, which they worked on with the counselor, which was if they were getting cash from the employer, they would deposit it right away with a mobile money agent. So that seemed like a feasible solution in the moment, which is something that we're continuing with in the larger trial. So this was a reactive adaptation. Then we also found that there were other leisure activities or alternative reinforcers that men preferred over the things that we had kind of suggested in the intervention. So they found that digging in the garden, or gardening as we might call it, was a preferred activity versus other things. So we will be providing seeds for planting during one of the intervention sessions. They also express a need for more sessions over a longer time. Similarly, we had a little bit lower fidelity for our first intervention session, and we feel that with our preliminary outcomes, we could see a greater change in those outcomes. So we increased the dosage and we extended the duration of the intervention in response to that feedback. So here are our aims for our larger trial. We will kind of obviously look at the efficacy of the intervention and its components, so we're breaking apart some of the components to be able to look at those separately on our primary alcohol and HIV outcomes. We are also looking at well-being outcomes, so psychological, physical, and socioeconomic well-being outcomes. And then we have our third implementation science aim, which I'll explain separately. So for primary outcomes, we're assessing the limitations, obviously, we had in the pilot trial. So we have a biomarker for antiretroviral adherence. We're obviously measuring viral load. And then we're also having quantitative measures of our behavioral economic mechanisms. In the trial, we only had a quantitative measure for the one of those, and in this trial, we'll actually be quantitatively measuring all of those as well. So we think we'll get some interesting findings around that. Then for our third aim, which is our implementation science aim, we're structuring this using the exploration, preparation, implementation, and sustainment framework, or the EPIS, really to identify facilitators and implementation strategies to overcome barriers to integrating the intervention or its components into clinical care, depending upon which components end up being the ones that might be scaled up. So in this aim, we're going to be collecting data and meeting with implementers, clinic level stakeholders, and district and policy level stakeholders. And we're going to be doing this throughout the trial, so not just at the end, so that when we get to the end of the study, we'll really be ready to scale up whatever model or whatever part of the intervention is appropriate. And we did this because when we shared the results of the pilot with the Ministry of Health, they're like, okay, great, this works. Let's scale it up. And we're like, well, this is just a pilot. We need to gather more evidence before we scale this up. So we wanted to make sure we were involving them throughout the trial and then sharing results as soon as possible. So then as part of the study, we can actually start to work with them on making decisions about what they want, like how scale up should look, kind of what's feasible, what's not. And we're also doing costing as part of this aim, not a formal cost effectiveness analysis, but costing to help inform some of this decision making. Then kind of as we think about where we are in the current context, we're certainly anticipating future challenges and how these things may affect our study. Even its own funding aside, we won't talk about that. But there's the broader context of funding for global health and aid funding and how that may change just routine care for HIV. There are already changes in the works that, in both positive and negative ways, that HIV care has been kind of siloed and that it has its own clinic days, which the Ministry of Health is already starting to change, and it's going to become more integrated with the rest of care, which I think maybe in the long run is a positive. Unfortunately, there'll just be less funding for it, but that will obviously kind of affect how our study is implemented. But that's something that I see as a positive challenge in the long run. We also, as I mentioned, this study will be much more integrated with Ministry of Health throughout its course. We have some good folks that we are very interested in this that we're working with, and so that's really exciting. So I want to acknowledge kind of all of our community and health system partners, my collaborators, student postdocs and trainees who've been involved with this work. And I'm very grateful for working with all of them. And then I want to just end with kind of where we started, which is thinking about kind of where do we go from here with kind of where we're at with public health and where we're at with public health as academics. And I'm not saying this is a definitive answer to the question I posed at the beginning, but these are just kind of my thoughts based upon my work. In that, I think one way to go is building trust through partnerships and kind of reflecting on the definitions I offered of public and what that means in the context of public health. I think for me, we can always do better. And I think we always need to think about doing better. And for myself, I'm always reflecting on, what did I do right? What did I do wrong? How can I improve in the work that I do? Am I doing the work that is sort of core to the work that I should be doing, that is really motivating me on a day-to-day basis? So kind of keeping with the theme of the definitions, I would say that doing impactful research and scholarship that's in service of the community, producing knowledge that's available for everyone, so making sure that we share our research with everyone. And also, I think this last point for me is kind of speaking to how do we kind of address some of the mistrust, is learning and figuring out how to honor, respect, and collaborate with things that are accepted as generally known in a community, and things that may sometimes conflict with what we consider to be scientific knowledge. And I know that will be challenging, but I think learning how to kind of reconcile conflicting views and how do we kind of work with that as public health academics. So I'll leave you with that big and confusing thought. But thank you.
Thank you for the presentation. It's great. It's really interesting. Excuse me, what you mentioned about mobile money, because my understanding, at least from the economics literature, is it's the other way around. That economists actually have a term for pain of paying, where once you move to a cashless society, you actually get less knowledge of what you're spending on, and actually you accumulate more debt. And I've been thinking and working with this with like the Ministry of Health in Sudan. So it's interesting to me that you found the opposite, and also I'm not sure if you can go back to the literature that shows it's the other way around. Was the friction that the alcohol entities did not have like mobile money, or where did that friction come from?
So they will take mobile money, some of them. I think the fishing communities are a little bit unique because some of them are remote, and so there is kind of less acceptance of mobile money. So and then I think there's the other piece of that mobile money, costs money to sort of use. And people are somewhat resistant because of that. The other thing in fishing communities that's a little bit unique is I'd say there's a little bit more crime in that there's the incentive to use mobile money because there's a risk of theft of cash. So that's another kind of incentive, but the kind of disincentive of paying with mobile money is that there's a fee involved, and the government also taxes it.
That's
they take money, which people don't really like. But I think if they see that there's a savings benefit, they also have savings accounts on, like interest-bearing savings accounts on mobile money. which I don't think are super well utilized, but we try to do some education around that. So I think some people see the benefits of it, but I think that piece around sort of awareness of spending is interesting. I think there's certainly some issues around sort of the loan piece on mobile money that's interesting. That people do, I think, can get into some trouble around the loan piece, but in our population, we haven't seen a lot of use of the loan piece.
Thank you.
Yeah.
In the vein of producing knowledge available for everyone, I think one of your slides had like a report of like a returned result type of report for community folks and the parents that were having children return back to school. Can you speak a little bit about almost like adapting those reports for specific community groups, feedback from groups, and then kind of adapting them to be suitable in a way that community understands and what that process looks like for you and your team?
Yeah. Well, I have to say that it's been a learning process for us. I can't say that like we necessarily know that we're good at it or not.
Yeah.
But it took a lot longer than we thought it would. It took a really long time. So I have great respect for people who are good at this. So we kind of worked with the school district and kind of key groups, like parent groups within the school district to sort of first like kind of present some findings like in meetings and like, okay, well, what do you think about these things? Do you think these things are important? And got feedback and kind of use that guidance to kind of come up with what it is we would present. And then, kind of went through many iterations of, well, how do we present this that's in a way that's understandable, that's not too text heavy? If you want my honest opinion, it's probably a little too text heavy. The videos we made probably were more simple because no one's going to watch a very long video. So we have like 3-minute videos, then we have some 30-second clips. But even writing the scripts for those was a tremendous amount of work that, you kind of don't realize when you're doing that. And I don't, to be candid, I don't know if, did we pick the right messages? I don't know. But I think we did the best that we could in terms of trying to give some options of things we thought were interesting and important. But I think what we find in the research side is not necessarily what's most like interesting and impactful to people in the community, because like kind of our sort of boring research things are not very interesting. And sometimes they don't translate very well to like what's important to like in someone's daily life, right? So that was kind of hard to be like, okay, well, some of these things don't translate and that's okay. We don't necessarily need to share those boring things. And sort of like getting over that hurdle, I think, was like, yeah, we don't need to share that. That's boring. So it was a big learning experience. In Uganda, we regularly share our findings with the community more through presentations. And I think I found that experience easier. I'm not sure why. Maybe because we're more used to doing it, and maybe what we've done is kind of it more clearly has like an impact, I suppose. But I think in this particular study, it was challenging. So I guess I certainly have more respect for people who do a great job at this kind of stuff, and I wouldn't say that we are experts by any means.
Thank you.
Yes.
Thank you. Great presentation.
Thanks.
I have a couple of questions. The first is, I'm curious how age played a role in sort of confounding some of these relationships. In our research in Kenya, the fishing communities are aging. And so I can imagine that it would be related to alcohol consumption, HIV transmission, and all of that. That's the first question. The second one is, what has been your experience with the flexible RCT? Are you receiving any pushback? You have a lot of purist RCT people in the world. So I'm curious to hear.
So maybe, what do you mean by the flexible RCT?
Well, the frame or the modifications to
Oh.
yeah.
Well, I guess on that side, I mean, I was sort of trained as more of like a traditional clinical trial person. But I mean, honestly, in terms of, but I guess I've always done work like sort of in the field, for lack of a better term, because I mean, it's not like I can do this work like in a academic hospital or something. So I guess, challenges happen and I mean, it's almost inevitable that you're going to have to change something. And whether or not you do a good job of documenting it and why it happened or not, I think, again, I guess if I want to be candid, I don't know that people always do a good job of documenting changes that are being made, right, or reporting. But I guess I felt like, and again, here's where I feel like at this university, I'm a little nervous talking about implementation science stuff, but I felt like I wanted to make sure we were documenting this because I felt like actually it was interesting of like, why did we make these changes? And sort of like what changes were made when and what was the rationale? And then kind of as we go forward, what changes are we making? Like, for example, as we've been training our implementers, they're like, okay, well, we need to change this. And it's like, okay, well, we made a change because people weren't really understanding the alcohol risk levels. So that made the session longer. Now the session's too long. So now we have to move some content to another session. And these things are happening. And it's interesting as to why we're making the changes and sort of who's driving that change. So I guess my short answer is I think it's always been happening, whether or not people are documenting it and kind of telling the story behind it. And I guess that's sort of part of the point of my talk today was to tell some of the stories behind it. And I didn't have enough time to tell all the stories behind some of these things, but to me, that's kind of some of the interesting stuff. And your first question around age, and this is where I'm struggling with my memory a little bit. But if I remember correctly, so we didn't specifically see, because age was so closely related to duration on ART, we didn't see any effects for age related to alcohol use. We would have seen kind of age effects on like adherence, but it's closely, it's highly correlated with how long they've been on ART. So we kind of chose to control for that instead, just because it was, the most relevant. So I don't have like a precise answer on that for you. Yes.
Question going back to your COVID study.
Mhm.
You had one group that got this at-home testing model and one that had the school-based model. Did you have any say or control over the messages people received in either group? Because I'm thinking about how polarizing COVID became over time, and could that impact how people perceived it in school testing if people were discussing their thoughts or feelings about the testing procedures or mandates in the school, how that might impact people's response?
Yes, that's an excellent question. And it was kind of a question or a part I didn't get to talk about was, and I think this came about more when we were scaling up, but we did have to make a lot of, I guess, we had to have a lot of flexibility by school. Schools were, as you might imagine, very different. And so, for example, just in how you communicate in a school, some schools, it's like parents want everything on paper. Other schools, parents want you to communicate by phone, by text message. So implementation of things were very different. We also had schools where they were more kind of resistant around testing. And we had to kind of craft messaging that would be kind of in line with community values in those schools to kind of combat some of that resistance. We didn't see it as much during the trial because COVID was still there was less COVID fatigue at that time. But we certainly saw it during like the scale up and the full scale, where we did have to make a lot of kind of adaptations by school because they are just very different, even within a district that's overall a low socioeconomic district. There were some schools that were like higher than others, and those tended to be the schools that had lower participation, which is an interesting finding that I didn't have a chance to
That's what you
discuss.
do with the results, right? If you have to keep your kid home from school,
Right.
if there's a positive test, you're probably not gonna want your school to be testing your kid every week, you know?
Yeah.
I have a question also to complete the 3 in 1. I also have a question about the schools, kind of related and thinking particularly about this, your last point here on the slide. And I'm wondering what, COVID's kind of done. And I'm wondering what kinds of lessons could go towards other maybe hot button public health issues that involve children in schools. I mean, thinking specifically of measles, like it's not in all the schools right now, but like, who knows? And just, I think people initially started COVID with an open mind towards it, but obviously people are coming into measles with a lot of thoughts. And so how do you think about some of these, what you learned in terms of especially those schools that maybe were more resistant, even thinking like, it was clear that this like worked, right? In your sort of per protocol, like the schools that were engaged, fewer kids had COVID days. Like how you would go about taking those lessons into something, the next thing.
Yeah. Well, I mean, the approach we took in the COVID work was really kind of working with each school and figuring out kind of which kind of how to frame messaging that kind of wasn't butting heads with what, because I think, I mean, I'm not a communications person expert, but what seemed to work was sort of not trying to like say you're wrong, but sort of figuring out how to kind of craft messaging that was not directly kind of getting at the thing they were disagreeing with, but maybe tapping into something that would be consistent with values, like test because you're protecting your community, maybe not because like, it's something you're doing for yourself, or, that's an easy one, but and that probably wouldn't work for measles. But just trying to work with the particular school to figure out what messages would resonate in that particular community and wouldn't be kind of amp up resistance because they're contrary to what people are believing.
All right, well, you're at time.
Okay.
So we want to thank everybody for coming and great questions.